Muy buenos días. Vamos a iniciar la tabla número 2. Mi nombre es Ángel Cequier, del Hospital Universitario de Albiche. Quiero agradecer a la organización, especialmente a Fernando, esta amable invitación. I have the pleasure to have a moderator, Dr. Adnan Kastrati. It's from the Herzentrum German Center for Cardiovascular Research in Munich, Germany. Y tengo también el placer de tener entre nosotros a tres excelentes panelistas: Manuel Sabaté, de Barcelona, Chema del Hospital Valdecilla de Santander y Juan Sánchez de Valencia. Tenemos exactamente 5 presentaciones a realizar por 4 excelentes speakers y entendí que la discusión se iba a hacer al final de las 5 presentaciones. De acuerdo, pues si os parece vamos a empezar la primera presentación. Do you want to introduce the first speakers?
Yeah, the first speaker is Bruno Scheller, and the title of his presentation is DEB for Inset Reestenosis, Registries, Randomized Studies, and Metaanálisis.
Okay, so thank you very much. I will focus not on specific trials, because these are part of the talks. The RIPS trials will be presented by Fernando later on, and I think we'll have more data on it. What you can see here is a meta-analysis from 2015, including all the trials comparing DCB and drug-eluting stents for the treatment of instant Reestenosis. And as you can see, if you look at the DES versus DCB comparison, TLR was very similar at 1 year myocardial infarction. No significant difference, but a little bit better in figures for the DCB. Mortality, no difference, and MACE also no difference. So from this data set in 2015, it was very clear both treatment options at 1 year have similar efficacy, and this is one of the reasons why we have this equal recommendation in European guidelines from 2014 for the treatment of BMS or DES Reestenosis. You can use whatever you want. At least it should be a drug-eluting stent, a second drug-eluting stent, or a drug-coated balloon. So both have a class 1A recommendation for the treatment of instant Reestenosis. The discussion changed a little bit, especially since Fernando published the RIPS-4 trial. This trial compared DCB with everolimus-eluting stent for the treatment of drug-eluting stent Reestenosis. And if you include this trial in the analysis and look at especially at TLR, there seems to be a benefit of the stent-in-stent approach over the DCB approach. Fernando will give you more details on the RIPS trials later on. Coming back a little bit to a few selected trials from the past, the first main trial was the Packard ISR-1 trial. It was conducted in bare metal stent Reestenosis, and this prototype DCB, the Packard, was compared to POBA. The reason why we did this design was that it was designed in 2003. At this time, drug-eluting stents were not yet approved for the treatment of instant Reestenosis, and POBA at this time was the gold standard for more or less for the treatment of instant Reestenosis. And we could mechanistically demonstrate that DCB works in the treatment of bare metal stent Reestenosis. Late lumen loss was reduced from 0.7 to almost zero in this patient population. And later on, the good news was that this initial benefit really lasted over a long follow-up period at 5 years on and more. In the RIPS trials, one of the newest ones for the treatment of metal stent Reestenosis is the RIPS-5 trial, showing angiographically better results with the use of the everolimus-eluting stent. But I want to point out another interesting finding, and this is the question what to do with your therapy if there's a failure. What to do if stent-in-stent fails, and what to do if DCB in stent fails. And there's an interesting pattern which has also been seen in the ISAR-DESIRE-III trial, namely that if you have Reestenosis after DCB use, physicians tend more frequently to retreat this lesion. If you have a failure after stent-in-stent, there's a lower tendency to retreat. So the question is why, and is this a benefit or not for the DCB? In my opinion, it is a benefit because you have more treatment options after failure of the therapy because you still have only one layer of metal and not 2 layers of metal. In another BMS trial, the PLEVA trial recently published, this pattern was not seen. There was the same behavior if you had Reestenosis after DCB or Reestenosis after standard stent. This is a summary of randomized trials comparing DCB with PROBA or with earlier generation drug-eluting stents, and all these trials led to these recommendations in the guidelines. If you look at RIPS4, treatment of DS Reestenosis, again, this different behavior in what to do in case of failure of this therapy. And for me, this is again a sign that if you do not implant another layer of metal, you have more options for the future, even if angiographic outcomes are better with the stent approach. But this we can discuss later, I think. One important lesson we had to learn in the past is that lesion preparation is the most important step when using DCB, because you have to do the mechanical job without stent, and therefore you have to take more care on this approach. This is the actual concept of DCB, only lesion preparation. With every device you need to get an acceptable angiographic result. And acceptable means no relevant dissections. Type A and B are fine. They have a really good outcome. Bernardo showed his paper on this topic. There should be, of course, a TB free flow to not to implant stent, and the residual stenosis should be not more than 30%. This 30% is an expert opinion. You could also say 40% would be acceptable. This expert group but decided for 30%. And if you fulfill this, then you can use the DCB for treatment of de novo disease, or in this case for instant Reestenosis. If you do not fulfill this criteria, you should implant a current generation Lyme-eluting stent. And this concept has been confirmed, for example, from Antonio Colombo's group. They looked at treatment of instant Reestenosis and divided the groups in an adequate or inadequate result, and this adequate is exactly what we defined as an acceptable result. And this had a clear impact on clinical outcome if you fulfill these requirements. The ISAR-DESIRE-III trial has been discussed before, that you can improve your lesion preparation, for example, by the use of scoring balloons, and this has at least a beneficial effect on angiographic outcomes. However, the clinical outcome was not significantly different, either if you use a conventional balloon or the scoring balloon for the treatment of instant Reestenosis. Another interesting topic, in my opinion, is what is the consequence of your ISR treatment for long-term outcomes. We know that even for current generation drug-eluting stents, there is an increased risk. Oops, excuse me. Can I have the presentation again? I wanted to show that even with current generation drug-eluting stents, the risk for stent thrombosis is increased compared to treatment, thank you very much, of de novo disease. If you look at the DCB ISR trials, there was almost no cases of stent thrombosis. Overall, we have seen in more than 2,000 patients stent thrombosis rate of 0.2%. So there is reason to believe that avoidance of a second layer of metal may improve really long-term outcome. And we have some signs from randomized trials. First of all, PEPCAR China, 2 years follow-up. There was a significant difference in mortality for DCB versus first generation drug-eluting stent, and similar results, interestingly, from ISAR-DESIRE-III at 3 years. No difference in TLR between DCB and first generation drug-eluting stent, but a significant difference in when you combined mortality and myocardial infarction. So this was not a primary endpoint, but I think there is some sign that there may be a benefit in longer term outcome, and I think Fernando will present 3 years follow-up of RIPS4 at the TCT meeting I have seen, so it will be interesting to see what the results of this are. So the question is, when comparing DCB and stent for the treatment of Reestenosis, what are the optimal endpoint? Is it more angiographic endpoint? I think if you look more at angiographic endpoint at 1 year, there seems to be benefit of a current generation drug-eluting stents. But if you look more at long-term outcomes, there could be a benefit by the DCB approach when avoiding 2 layers of metal. So in my opinion, we can discuss this later, DCB should be the first-line treatment for in-stent Reestenosis, since we have no additional layers of metal, and this means decreased risk for late-stent thrombosis. There is a reduced need for prolonged dual antiplatelet therapy. We still recommend 4 weeks of dual antiplatelet therapy after DCB treatment when not implanting a new stent. I knew the new ESC guidelines tell us something different, but I doubt a little bit the basis for this recommendation. You can repeat the procedure because you have only 1 layer of metal, not 2 layers or 3 layers of metal, and possibly there could be a positive influence on hard clinical endpoint on longer term outcomes, but we need a randomized trial which are powered for this question, of course. And I think the disadvantages in angiographic outcomes could be reduced by careful lesion preparation, assuring a sufficient initial lumen gain. Thank you very much.
Okay, thank you. We move to the next presentation. The presentation is entitled ISAR-DESIRE-III on 4. It will be presented by Adnan Kastrati.
Thank you. So first of all, I would start with the story of ISAR-DESIRE trial, very short. ISAR-DESIRE was the first trial that looked at the efficacy of drug-eluting stents for bare metal stent Reestenosis. It was a trial of 300 patients, 100 in each group, Cypher, Taxus, and balloon angioplasty alone, because at the time, balloon angioplasty alone was a standard therapy for the treatment of bare metal stent Reestenosis. These are the results, the main results of this 3-arm trial, and you see that the best treatment for bare metal stent Reestenosis in this trial was Cypher, was the use of Cypher, and the second best treatment was the use of Taxus, and balloon angioplasty alone couldn't be compared with these 2 strategies of drug-eluting stents. ISAR-DESIRE-II trial followed the ISAR-DESIRE trial, and the question posed in that trial was what to do with drug-eluting stent Reestenosis. So the response, the answer for bare metal stent Reestenosis was the use of drug-eluting stents. Now in the cases, and the cases were increasing because ISAR-DESIRE-II trial came later after as the ISAR-DESIRE-I trial. The question here was, which is better for sirolimus in-stent Reestenosis, paclitaxel eluting stent, or a second sirolimus eluting stent? At the time we had Cypher and Taxus as stents. It was a relatively large trial with 450 patients with sirolimus stent Reestenosis, and these are the main results. Late lumen loss for both groups was very comparable. You see the curves are overlapping for both Taxus and Cypher stent. It was the first time at the time that Taxus was comparable with Cypher, because in all other settings, Cypher has been superior. After that, we designed the ISAR-DESIRE-III trial with the intention to evaluate also the drug-coated balloon. And we took 3 arms at the trial. One, balloon angioplasty alone, because this was the comparison, the real comparison with the paclitaxel coated balloon. And on the other side, we had also the Taxus stent, so we had the 3 possible therapies of in-stent restenosis of drug-eluting stents based on paclitaxel. These are the results here, and as you see, balloon angioplasty alone was very inferior to both stent-based and balloon-based paclitaxel strategies. Diameter stenosis was much higher at follow-up angiography. We were able to have more than 80% follow-up angiography rate in this trial. When we looked at the binary stenosis, it was the same pattern with a very high rate of restenosis among balloon angioplasty patients and very comparable rates of binary stenosis between the paclitaxel coated balloon and the paclitaxel eluting stent. Target lesion revascularization was also significantly different, higher in the balloon angioplasty and lower in both drug-eluting, drug-coated strategies. The most interesting result from the ISAR-DESIRE-III trial came after 3 years, and you see here the results regarding TLR, reintervention. So there is paclitaxel eluting stent was lower with 24%. It was for drug-coated balloon, it was also comparable, not significantly different as compared to the stent, to the Taxus stent, and very high for the balloon angioplasty alone. But the most striking result was when we compared death and myocardial infarction. You see here in this slide here, which this combined endpoint was much higher with the stent than with balloon-based strategies. It means that although Taxus was able to produce results that were comparable with the drug-coated balloon, at the long term, the results were much worse for the stent. ISAR-DESIRE-IV followed the ISAR-DESIRE-III trial, and you have seen a lot of slides here. Our intention was to evaluate the additional contribution of scoring balloon in these settings. How can help the scoring balloon to improve the results of drug-coated balloons in patients with drug-eluting stent restenosis. There are many hypotheses there, so the drug penetration and the better preparation of the lesion. And so it was said also here that it stabilizes the balloon dilation with this scoring balloon, and there is no slippery of the balloon there. So we don't know, but we wanted to know exactly, is scoring balloon affecting the results of drug-coated balloons in in-stent restenosis patients. It was a trial with 252 patients, and you see the main result is it was based on diameter stenosis, and the diameter stenosis was significantly lower in the group in which we used the scoring balloon. It means that the contribution was effective there, and it was able, the scoring balloon, it was able to reduce the restenosis in these patients. We couldn't see significant results regarding the clinical endpoint, but it was not also planned to have this, because with 250 patients it's very difficult to have significant clinical results. What are the successors of the ISAR-DESIRE-III and IV trial? We have completed enrollment of the DESIRE-3A study, which is a one-arm study. It's just looking at a new balloon, coated balloon, agent balloon. We plan to compare the results of this one-arm study with the particular eluting balloon arm of the ISAR-DESIRE-III trial. This is a prospective. It uses the same inclusion criteria, exclusion criteria as used in the ISAR-DESIRE-III trial, and you see here the criteria. The primary endpoint is the same, diameter stenosis, at follow-up angiography at 6 to 8 months. So we plan to have to enroll 100 patients. With this, we'll have enough power to look at differences in diameter stenosis at follow-up. So to have 102 patients with follow-up angiography, you need to have more enrolled patients, and that's why we completed enrollment of 125 patients in this trial. So we plan to present the results at the ACC 2018. Take-home messages for ISAR-DESIRE-III and IV trials: drug-coated balloon results in superior long-term outcomes compared to paclitaxel eluting stent. Lesion preparation of in-stent Reestenosis by scoring balloon improves the anti-restenotic efficacy of drug-coating balloon. Thank you very much.
Thank you very much. Vamos a pasar a la siguiente presentación. Lleva por título el estudio AGENT-ISR. Va a ser presentada por el doctor Alfonso Torres del Hospital Chagorritxu de Vitoria.
Pues en primer lugar yo quería agradecer a Fernando Alfonso su amable invitación a participar en este simposio. Y según el encargo que me hizo, pues me toca presentar este estudio, que es un estudio randomizado, que es el primero y hasta el momento creo que único estudio que ha presentado resultados de comparación directa entre dos balones farmacoactivos. El estudio fue presentado en el PCR del 2017 por el doctor Christian Ham, que es el investigador principal, y se realizó en 12 centros europeos. Y el objetivo del estudio era comparar la efectividad del balón AGENT de Boston Scientific con el de Sequence, que es un balón más conocido en cuanto a número de publicaciones que tiene, etcétera, ¿no? Las diferencias entre ambos balones consisten en el excipiente que lleva el balón y también en la concentración de droga que ponen en el balón. En el caso del AGENT, el excipiente es una sustancia que se llama Transpax, que es acetiltributilcitrato, y lleva una concentración de 2 microgramos por milímetro cuadrado de paclitaxel. Mientras que el Sequence lleva iopromida y lleva la concentración de paclitaxel de 3 microgramos milímetro cuadrado, que viene a ser la más frecuente que se pone en los balones de paclitaxel. En cuanto al efecto del coating del balón, se ha visto que el Transpax puede ofrecer la ventaja de permanecer más tiempo en el balón sin diluirse al entrar en contacto con el agua, mientras que otros balones pierden con más facilidad el recubrimiento. Entonces, estas son fotografías de microscopía electrónica que muestra al cabo de 10 minutos cómo se encuentra un balón u otro, dependiendo del tipo de coating, ¿no? Eso también se traduce en la pérdida de partículas que se pueden visualizar después de haber hecho pues, una manipulación del balón para subirlo hasta la zona donde va a ser usado, expandir el balón y recogerlo, y la cantidad de partículas también parece que puede ser diferente dependiendo de la tecnología que emplee cada cada balón. Bien, el estudio ISR-AGENT lo que ha hecho ha sido randomizar pacientes a utilizar el balón de paclitaxel AGENT versus el Sequemplis en lesiones de arterias coronarias menores de 28 milímetros, diámetros entre 2 y 3,5 y con un porcentaje de estenosis del 70% en caso de que los pacientes estuvieran asintomáticos o del 50% en caso de que estuvieran sintomáticos. Han excluido lesiones complejas, como son las lesiones de bifurcación, el tronco común izquierdo, la reestenosis en safenas, la reestenosis después con obstrucción total, los casos de reciente angioplastia coronaria o el infarto agudo de miocardio. La randomización que se ha hecho ha sido 1:1 y el objetivo primario es verificar la pérdida luminal tardía a 6 meses. Y está previsto hacer un seguimiento clínico de ambos grupos que va a durar 3 años. La terapia antiplaquetaria recomendada ha sido de 3 meses con un mínimo de 4 semanas y se mantiene de manera indefinida la aspirina. En cuanto a la organización del estudio, pues está puesta en esta diapositiva, son fundamentalmente centros de Alemania y de Francia los que han participado y han utilizado un core lab externo para verificar los datos de pérdida luminal tardía. Aquí está el objetivo primario, que, insisto, es la pérdida luminal tardía a 6 meses, que se ha medido mediante QCA. Y son también endpoints adicionales, pues endpoints clínicos típicos de muerte, infarto de miocardio, TLR, transversal revascularización, stent trombosis, etc. En cuanto a endpoints angiográficos, el porcentaje de estenosis en diámetro, la reestenosis binaria y el minimal lumen diámetro. También se ha hecho una revisión pues, mediante test de calidad de vida para comparar un caso y otro. El estudio es un estudio de no inferioridad que espera encontrar una diferencia no mayor de 0,2 milímetros entre los grupos para considerar que no existe inferioridad. Y se ha hecho una significación de 0,05 y con un poder de 0,90. Ello llevaba a una muestra que es pequeña, son 122 pacientes para una randomización 1. El flujo de pacientes ha sido como pone la diapositiva. Al final entraron 65 en el grupo del AGENT y 60 en el grupo del Sequemplis y posteriormente estaba previsto hacer un seguimiento angiográfico a 6 meses en el que hubo pues, unas cuantas retiradas en cada grupo, como también era previsible. Entonces hubo 7 en el grupo del AGENT y 6 en el grupo de Sequemplis, llegando al final a participar en el seguimiento angiográfico 51 pacientes en uno y 49 en el otro, lo que supone alrededor del 80% de los enfermos que se incluyeron. No había diferencias en las características clínicas de los pacientes. Sí que me parece interesante destacar que había una cantidad importante de diabéticos, en concreto pues casi un 40%, y de hipertensos con un 80% y de hiperlipémicos, es decir, son pacientes con muchos factores de riesgo y también con antecedentes importantes de enfermedad coronaria, como es el infarto previo que estaba presente en el 50% de los pacientes. Las lesiones no difirieron en sus características entre los dos grupos. Las longitudes medias eran más bien cortas, de 12-13 milímetros. No hay diferencias en el porcentaje de estenosis, ni en el diámetro luminal mínimo, ni en la presencia de calcificación o tortuosidad. Tampoco en las características del procedimiento. La duración del procedimiento fue igual en ambos grupos, el tiempo de fluoroscopia y las medidas finales de QCA fueron similares. El éxito del procedimiento fue prácticamente del 100%. Bueno, pues en cuanto al objetivo primario, no ha habido ninguna diferencia importante, como puede observarse en el gráfico, entre los dos balones. cumpliéndose el criterio de no inferioridad. La pérdida luminal media que se ha visualizado en el AGENT ha sido de 0,397 y en el Sequence Please 0,393, es decir, prácticamente la misma. En cuanto a los endpoint clínicos, tampoco se han apreciado diferencias significativas. Al ser un estudio con seguimiento geográfico, lógicamente hay una tasa mayor de TVF y TLF porque bueno, pues se hace por asignación binaria, ¿no? el resultado, ¿no? Considerando estenosis mayores de 50% como restenóticas. Y tampoco ha habido diferencia en cuanto a la calidad de vida con uno u otro brazo. La conclusión es que este es el primer estudio que enfrenta de manera directa dos balones de paclitaxel con diferente formulación de droga. El balón AGENT ha conseguido, con más baja concentración de droga, resultar no inferior al Sequence Please que en la pérdida luminal tardía. Y no ha habido diferencias en los aspectos de procedimiento, resultados angiográficos y resultados clínicos. Hasta el momento no hay datos de seguimiento a largo plazo y está previsto, como he comentado, pues un seguimiento a largo plazo que va a durar 3 años. Bien, entonces voy a poner algunos comentarios de mi cuenta. A mí me parece que el balón de paclitaxel es una buena opción para tratar la restenosis sin añadir capas de metal, pero en mi opinión creo que eso es así si el procedimiento está bien hecho. Y yo considero que debe predilatarse, hacer una buena predilatación. Soy partidario de utilizar balones sobredimensionados no compliantes, altas presiones, scoring balloon, etc. Y tener cuidado y atención al recoil agudo que puede obligar a implantar un stent. En este momento hay muchos balones en el mercado, pero no todos tienen evidencia publicada. Y este es el AGENT-ISR, es el primer estudio que presenta un seguimiento angiográfico a 6 meses en una randomización 1:1. Bien, de cara a largo plazo, voy a presentar una pequeña serie que nosotros tenemos en nuestro hospital, que se ha hecho precisamente casi en el 90% con los balones que se utilizaron en el estudio ISR, es decir, hemos empleado sobre todo el Sequence Please y el AGENT, y hemos hecho un seguimiento a 18 meses de los pacientes para saber qué había ocurrido con ellos. Y me parece interesante comentarlo, ya que no he tenido oportunidad de hablar de resultados a largo plazo con el estudio ISR, que todavía no están publicados. Entonces, en nuestra serie hay 58 pacientes incluidos y se trataron 68 lesiones restenóticas, y además de las lesiones restenóticas se trataron también otros vasos, de manera que el tratamiento fue de 1,43 vasos por paciente. Pues a 18 meses la mortalidad observada ha sido de 8,6%, 4 de las muertes han sido cardíacas, y curiosamente hemos visto que se ha producido mayor número de revascularizaciones ocasionadas por nuevas lesiones o lesiones restenóticas en otros segmentos que no estaban restenóticos en el primer estudio, o lesiones de novo, que tratamientos por nueva restenosis de una restenosis tratada con DEP. Entonces, para concluir, la lesión restenótica es una lesión compleja en un paciente complejo, tiene más factores de riesgo, en concreto diabetes. En nuestra serie también nos salía casi un 50% de diabéticos, mayor enfermedad en los vasos, y también se produce en segmentos que están más próximos a la restenosis, ¿no? Que son el tronco común izquierdo, la vena safena, la CTO. Estos no estuvieron representados en el estudio ISR, por ejemplo. Por tanto, podemos esperar peores resultados a largo plazo en el contexto de la restenosis que en un contexto de pacientes normales. En este momento, pienso que el balón de paclitaxel, el balón farmacoactivo, es una aceptable opción para el tratamiento de la restenosis, y hay que pensar que no todas las revascularizaciones después de una restenosis van a ocurrir por fallo de la lesión tratada por restenosis. Hay muchas lesiones de novo y también fallos de otros estenes implantados en el paciente, porque posiblemente el paciente puede tener algo que ver con el hecho de que tenga restenosis, no solamente su lesión. Eso es todo. Muchas gracias.
Thank you, Dr. Torres. It's my pleasure now to invite on the podium Dr. Alfonso, who is the father of the RIPS trial, the basis of all guidelines, all recommendations regarding the treatment of patients with in-stent Reestenosis.
Bueno, muchas gracias. Voy a intentar resumir para vosotros de la forma más breve posible lo que hemos aprendido durante estos años de los estudios RIPS. Pilar Jiménez Quevedo me dio hace poco los datos no publicados, que los ha comentado Manolo al principio, sobre la utilización en España de balones farmacoactivos. Fijaros, un 3.7% de todas las angioplastias que hacemos en restenosis y en otros contextos. Y el tratamiento, la actividad por reestenosis intrastent representa cerca del 5%, y eso ha estado estable en los últimos años, a pesar de que tenemos stents mejores, stents de segunda generación. Y de hecho esta visión se confirma por algún dato reciente como estos de hospitales americanos, en concreto los hospitales especiales del Veterans, donde cuando ellos analizan la actividad de restenosis que hacen en sus laboratorios, no solo no está decreciendo, sino en este estudio recientemente publicado se sugiere que incluso la actividad por restenosis podría incluso aumentar en algunas situaciones, como veis aquí. Otro aspecto que quiero señalar es que hasta hace muy poco, hasta hace 10 años, como hemos oído, todos pensábamos que el tratamiento de la restenosis era algo sencillo desde el punto de vista del sustrato anatomopatológico. Eran pacientes que tenían un sustrato homogéneo, que era una hiperplasia neointimal. Y así pensábamos que ocurría en todos los casos, hasta que Renu Birmani, con estudios patológicos y también otros grupos, pues demostraron que en muchos pacientes puede aparecer una placa de ateroma dentro del stent, que es lo que hemos estado describiendo con los estudios de imagen y que se llama neoaterosclerosis. Y esto es importante por dos motivos. En primer lugar, porque ahora clínicamente podemos diferenciar estos pacientes. Aquí se ve en B un patrón, vamos a decir, sano de una neoíntima, homogénea, brillante y en este caso con una luz residual muy buena. Sin embargo, en D veis que existe otra zona del stent donde hay roturas en la superficie, donde hay una gran placa lipídica que oscurece los stratos posteriormente y que en algunos casos como este, que es muy llamativo, se presenta con una trombosis, es decir, que la presentación clínica es más de una trombosis del stent que de una restenosis como clásicamente la entendemos. Es decir, que tiene unas implicaciones patofisiológicas que yo creo que son muy, muy importantes. Como sabéis, todo este tema, todo lo que estamos hablando hoy, empezó por el estudio pionero de Bruno, que publicó en el New England, que demostró precisamente en pacientes con restenosis intrastent que si comparábamos el balón convencional, que es lo que utilizábamos entonces, versus un balón nuevo de plaquetaxel, este último dispositivo producía una reducción drástica de la tasa de pérdida angiográfica tardía y también de la restenosis analizada como un fenómeno dicotómico binario. Nosotros en los últimos 15 años pues hemos hecho, como sabéis, y con la ayuda de muchos de los que estáis aquí, los estudios RIPS. Hemos hecho 10 estudios prospectivos. Ahí en amarillo he señalado los que son estudios aleatorizados. Ahora estamos haciendo este último con la ayuda de la sección o dentro de la sección, que es ver qué pasa con la restenosis de los stents en dispositivos bioabsorbibles. Pero me voy a centrar obviamente en los estudios que hemos hecho con el balón de droga, que son el RIPS 4 y el RIPS 5, que los voy a resumir muy brevemente a continuación. Estos son estudios hechos, como digo, por muchos de vosotros. Fijaros, 25 hospitales universitarios en España han participado en estos estudios. Los estudios fueron coordinados desde el Hospital Clínico San Carlos y hay muchísima gente que ha trabajado en estos estudios, pero yo siempre quiero reconocer a Pepa. Pepa es el alma mater de estos estudios a nivel de base de datos crítica y análisis estadístico con Cristina, pues es la base, como digo, de estos estudios. Muy brevemente, ¿qué se encontró en el RIPS-5? El RIPS-5 es un estudio donde veíamos pacientes con restenosis de un stent convencional y, fijaros, 200 pacientes que fueron aleatorizados a las mejores estrategias que teníamos entonces. La utilización de un stent de segunda generación, que luego resultó ser el mejor stent que había en ese momento, o la utilización del balón de plaquetaxel que más evidencia había demostrado científicamente, el Sequence. El objetivo primario del estudio, que fue el diámetro luminal mínimo a los 6-9 meses de seguimiento, podéis ver aquí cómo fue claramente superior en el brazo de stent de Verolimus en comparación con el balón de plaquetaxel, y los mismos resultados se confirmaron cuando se hizo el análisis centrado únicamente en la lesión. Aquí veis cómo el mecanismo en cuanto a porcentaje de estenosis por diámetro es que con el stent se consigue un mejor resultado angiográfico, eso lo sabemos todos, y se obtiene una menor lesión residual de diámetro. Y esto hace que los resultados en cuanto a diámetro luminal mínimo y porcentaje de estenosis en el seguimiento sean claramente superiores. Fijaros, sin embargo, cómo la restenosis dicotómica es baja, cerca de un 5 versus un 10%, las diferencias no eran significativas y en este estudio tampoco hubo diferencias clínicas en el primer año de seguimiento. Incluso si analizamos solo el TLR y el TVR, solo había una tendencia a que el stent era algo superior, pero una tendencia lejos de ser significativa. El año pasado, en París, sin embargo, presentamos los datos de los 3 años de seguimiento del RIPS-5 y podéis ver aquí cómo, aunque la mayor parte de los endpoints combinados importantes no había diferencias, había una diferencia marginal, pero que fue estadísticamente significativa en el TLR. Es decir, que parece que con el tiempo pues hay una pequeña diferencia en favor del stent de Verolimus cuando tratamos restenosis en stent convencionales. El RIPS-4, como sabéis, es el mismo diseño, pero esta vez en pacientes con restenosis de un stent farmacoactivo. Más de 300 pacientes, de nuevo un seguimiento angiográfico que gracias a todos los centros fue muy bueno, 90% de los pacientes elegibles, y de nuevo el objetivo primario, el diámetro luminal mínimo en el seguimiento. Fijaros cómo es mejor tanto en el análisis in segment como en el lesion en el brazo tratado con stent de Verolimus. De nuevo, cuando vemos las frecuencias acumuladas de porcentaje de diámetro de estenosis, veis que el stent consigue una menor estenosis residual. Quizá las diferencias aquí no son tan llamativas, pero fueron altamente significativas, y eso en el seguimiento se traduce en unos mejores resultados angiográficos que hace que la tasa de restenosis tienda a ser diferente. Fijaros, cerca de un 10% versus un 20%, el doble una con respecto a otra, aquí la P es en el límite, pero acordaros que es casi el doble en ambos grupos comparado con lo que veíamos en el RIPS-5. Aquí sí, las diferencias clínicas se debieron a esta mejoría angiográfica, y estas diferencias clínicas se debieron exclusivamente a una menor tasa de TVR y TLR en el brazo tratado con stents. Ahora en el TCT vamos a presentar los datos de los 3 años de este estudio, y estoy especialmente contento con el esfuerzo que han hecho todos los investigadores, porque de nuevo tenemos un 100% de seguimiento clínico, que no está mal a los 3 años de los 309 pacientes incluidos inicialmente, para ver un poco la evolución clínica a largo plazo de este estudio. En el RIPS hemos colaborado en algunos otros estudios, por ejemplo, en los metaanálisis en red. Ya sabéis que los metaanálisis en red, aparte de comparar un dispositivo A con un dispositivo B de forma directa, lo que hacen es sacar todo el jugo, todo el valor de las comparaciones indirectas. Pero en este metaanálisis en concreto, los únicos estudios que compararon el stent de Verolimus con el balón de plaquetaxel fueron los 2 estudios RIPS, o sea que yo estoy orgulloso de eso. ¿Qué es lo que demostró este metaanálisis? Fijaros, son casi 30 ensayos clínicos, con casi 6.000 pacientes incluidos. Pues lo que se vio es que si consideramos que lo importante es el porcentaje de estenosis del diámetro en el seguimiento, veis cómo la terapia que mejor salió en estos estudios, en este ranking, fue el stent de Verolimus, seguida del balón de plaquetaxel, que incluso fue superior a los stent farmacoactivos de primera generación, tanto de sirolimus como de plaquetaxel. Este es el resultado de este metaanálisis. Otro aspecto interesante es qué pasa si nos centramos solo en los datos del balón de los estudios RIPS. Fijaros aquí, para que sea fácil de entender, la pérdida tardía, en verde están los balones convencionales y en azul clarito tenemos los balones de plaquetaxel que utilizamos en los estudios RIPS. Fijaros como en el RIPS 1 la pérdida tardía angiográfica es entre 0,7 y 0,8 en el RIPS 2, stents convencionales, y cuando en stent convencionales, que fue el RIPS 5, utilizamos el balón farmacoactivos, fijaros una reducción dramática de la pérdida tardía que se obtienen con estos balones. Es decir, que está claro que en reestenosis intrastent el balón de plaquetaxel es altamente efectivo. Y también está claro en este estudio, en la última columna, que cuando usamos el mismo balón en reestenosis de stent farmacoactivos, esto fue el RIPS 4, los resultados siguen siendo muy buenos comparados con el balón y muy buenos incluso comparados con el balón en bare metal stent reestenosis, pero son algo peores. Esto es un poco lo que vamos a ver ahora. ¿Qué pasa si comparamos los datos de los balones con droga, balón de plaquetaxel, en pacientes que tienen reestenosis de un stent metálico versus reestenosis de un stent farmacoactivo? Pues como aquí veis en este análisis conjunto que hicimos de los estudios, pues lo que se ve es que la diferencia en el diámetro luminal mínimo está a favor del stent metálico. Los resultados con el mismo tratamiento son mucho mejores en el stent metálico convencional que en el stent farmacoactivo. Hicimos un ajuste bastante complejo por posibles factores de confusión, porque esto no es el estudio aleatorizado como estaba planeado, pero veis que incluso después del ajuste las diferencias fueron significativas y eso se tradujo en una menor tasa de TLR en el seguimiento en estos pacientes. La otra cara de la misma moneda sería este estudio, es decir, bueno, tenemos una terapia que decimos que es un poquito mejor, la implantación de stent de segunda generación influye mucho que estemos tratando un paciente con una reestenosis de un stent convencional o un stent farmacoactivo. Pues de nuevo se demuestra, y aquí la diferencia es incluso mayor, que los resultados en cuanto a diámetro luminal mínimo en el seguimiento son mejores cuando lo que se trata con un stent de Verolimus es un stent convencional con reestenosis en comparación con una reestenosis de un stent farmacoactivo. De nuevo, las diferencias persistieron después de un ajuste estadístico y se tradujeron en una menor necesidad de TLR en estos pacientes. Y más recientemente, con el doctor Kastrati, hemos participado en este estudio, el estudio de cooperación Icarus, que veis aquí, que ha sido publicado hace poquito en Revista Española de Cardiología. Adnan lo que hizo es, buscó la colaboración de 6 ensayos clínicos, fijaros 500 pacientes en total, de estudios en los que se había utilizado el balón de plaquetaxel y tenían seguimiento angiográfico sistemático. El más del 90% se consiguió. La tasa de reestenosis medida por QCE en todos los pacientes fue de media un 20% y este es el primer estudio que con esta metodología bastante rigurosa ve cuáles son los predictores de reestenosis tras tratamiento con balón de fármaco. Y son dos circunstancias que los cardiólogos intervencionistas conocemos muy bien: el tamaño del vaso y su longitud. Son los únicos predictores independientes de reestenosis recurrente en este estudio que se llama la cooperación Icarus. Y quizá por acabar, pues decir, bueno, ¿y qué pasa con las estrategias del Leave Nothing Behind? Vamos a no dejar nada detrás. ¿Qué pasa con los BBS? ¿Qué pasa con el Absorb? Sabéis que hemos hecho el RIPS 7, el RIPS 6 también, y veis aquí cómo básicamente son los mismos tipos de pacientes, los mismos centros fueron invitados a participar, 140 pacientes tratados con el Absorb por reestenosis intrastent, y lo que hemos hecho es compararlo con todos los tratamientos con balón de droga del RIPS 4 y el RIPS 5 y todos los pacientes tratados con stent de Verolimus en el RIPS 4 y RIPS 5. Y aquí veis un poco los resultados de forma muy resumida. Lo interesante es que el balón de droga consigue la misma ganancia que el Absorb, al menos en este contexto, y que la pérdida tardía también es la misma. Es decir, que las dos estrategias de Leave Nothing Behind serían muy similares y al menos en nuestras manos o con nuestros datos son significativamente peores que la implantación de un stent farmacoactivo de última generación. Y eso se traduce también en similares resultados clínicos. Fijaros cómo en verde la curva del endpoint combinado es exactamente similar con los BBS que con los balones farmacoactivos. Quería simplemente concluir diciendo pues un poco lo que hemos dicho hasta ahora. El tratamiento de la reestenosis intrastent sigue siendo un problema clínico relevante. que tanto los balones de farmacoactivos como los stents de Verolimus son terapias eficaces en este contexto, y así lo reconocen las últimas guías clínicas de revascularización, que desde el punto de vista angiográfico los stents consiguen no solo unos mejores resultados iniciales, sino también unos mejores resultados a largo plazo, y que quizá en subgrupos especialmente complejos o problemáticos, como podría ser la reestenosis de un stent que ya es farmacoactivo, los resultados de los stents de Verolimus sean superiores, incluso con beneficio clínico, en comparación con los balones de fármaco. Como hemos discutido en la primera mesa, nos queda por aprender si podemos identificar mejor el sustrato que causa la reestenosis para utilizar esta información y guiar nuestro tratamiento teniendo estos datos cercanos a la patología en cuenta. Esta es una cosa que todavía no hemos sabido hacer y obviamente hará falta nuevos estudios y nosotros estaremos encantados de seguir haciéndolos para conocer cuál es el mejor tratamiento de los pacientes en nuestro medio que sufren una reestenosis del stent. Muchas gracias.
Muchas gracias, Fernando. We will move to the last talk. It's entitled Advances in the Treatment of In-Stent Reestenosis. Again, it will be presented by Dr. Kastrati.
So my job was facilitated by many slides shown before, and Fernando showed also the network meta-analysis of 27 trials, including more than 5,900 patients with long follow-up, 6 to 60 months. You see that the biggest cycle is the balloon angioplasty, because most of the trials had as a control group balloon angioplasty. And the cycles for drug-eluting balloons are almost similar in size, and most of the cycles are the contribution of RIPS trials, having the everolimus-eluting stent as experimental treatment. We had a very diplomatic conclusion in this network meta-analysis. Two strategies should be considered for treatment of coronary in-stent restenosis: PCI with the everolimus-eluting stents because of the best angiographic and clinical outcomes, and DCB because of its ability to provide favorable results without adding a new stent layer. What is new after this meta-analysis encompassing most of the trials in this field? Is ISAR-DESIRE-III trial, which looked at the additional contribution of scoring balloon. I have shown before the results for this trial showing a contribution, significant contribution to the angiographic efficacy of this combination in patients with in-stent restenosis. And exactly this kind of concept is used in the combination of scoring balloon plus coating balloon in the Angiosculpt X drug coating scoring balloon. You see here this, we are using it more and more in patients with in-stent restenosis, because with this you can save one step, so the separate use of a scoring balloon and after that of the drug coating balloon. You have also heard here that sirolimus is coming more and more on the stage for patients with in-stent restenosis. Here is one version of sirolimus coating balloons or eluting balloons, the Virtue balloon, which is eluting sirolimus from the balloon. We have to look whether sirolimus brings more advantages as compared to paclitaxel in patients with in-stent restenosis. Here is the SABR trial. It's a very small trial. It was shown before. That's why I'm not spending much time with it. But it is a one-arm trial. That means that there is no control group, and many of the patients violated the protocol. And so there are two kinds of analysis: intention to treat with all patients, irrespective of what kind of treatment they had at the end, and per protocol, looking only at the patients who had this sirolimus eluting balloon. The results were good for sirolimus, but you have to consider the limited number, the high violation rate, and the lack of control arm in this trial. What we have learned so far on in-stent restenosis. There are differences in angiographic morphology after in-stent restenosis of BMS and drug-eluting stent. So if we look at the proportion of patients presenting with focal restenosis or diffuse restenosis among bare matter stents and drug-eluting stent patients with restenosis, you see that there is the biggest difference is in the proportion of focal restenosis. Focal restenosis is much more prominent in patients with in-stent restenosis of drug-eluting stents. So 63% versus 40% in patients with bare matter stent restenosis. What have we to expect knowing this proportion of patients with focal and diffuse restenosis? If you look at the primary publication that evaluated the outcomes of patients with different patterns of angiographic restenosis, it was the paper published in '99 from Roxana Mehran, you see that TLR is at lowest in patients with focal in-stent restenosis. So that means that for patients or for a group of patients having a higher proportion with focal restenosis, you have to expect a lower recurrence rate. What is the reality for patients treated with drug-eluting stents or drug-coated balloon for in-stent restenosis? If we compare the outcomes as we have done here for patients with in-stent restenosis of bare matter stent and drug-eluting stents, you see that both patients were treated with sirolimus eluting stent, with cipher stent. The restenosis rate was higher if the patient had drug-eluting stent restenosis. That means although these patients with drug-eluting stent restenosis have a higher proportion of focal, they demonstrate a higher recurrence rate if they are treated with sirolimus eluting stent. It's something that is not logical. Let's look further. It was shown a more sophisticated analysis from Fernando. I did a very a general analysis here, looking at drug-eluting stents and drug-eluting balloons for patients with BMS restenosis and patients with DES restenosis. These are the results from RIPS-4 and the RIPS-5 trial. Let's look how is conducting the DEP for patients with in-stent restenosis. If we treat in-stent restenosis after DES, you have, and here it's important to know, you have a smaller diameter, minimal lumen diameter, as if you treat patients with BMS restenosis. That means that DEP is being more effective for BMS restenosis than for DES restenosis. Let's look at the everolimus eluting stents. The same pattern. You have 2.2 diameter if you treat patients with drug-eluting stent restenosis, and you have a larger minimal lumen diameter of 2.44 if you treat patients with BMS restenosis. Even here, patients with BMS, although they demonstrate a higher proportion of diffuse disease, diffuse restenosis, they have better chances after treatment either with DEP or with drug-eluting stents. I've done a very fresh analysis of our patients in the ISAR-DESIRE-I and ISAR-DESIRE-II trial, looking exactly at this issue. What are the results of BMS restenosis? What are the results of DES restenosis if they are treated with a conventional, very conventional strategy, balloon angioplasty? Here also, patients with BMS restenosis show a diameter stenosis which is lower than patients with DES restenosis at 6-month follow-up angiography, both treated with balloon angioplasty alone. So we have results for balloon angioplasty alone. We have results for drug-coated balloon. We have results for drug-eluting stents for in-stent restenosis in both patients with BMS and patients with DES restenosis. In all the cases, irrespective of the type of therapy you are using for the second treatment, the results are better for BMS restenosis, which is not explained by angiographic morphology. Even in this analysis, you have also a higher TLR in patients with DES restenosis. If you treat patients with BMS restenosis, you have a chance of reduction of 20% in TLR up to 2 years. So if you compare DES restenosis with BMS restenosis. That means that this angiographic morphology pattern is not helping us in the case of drug-eluting stent restenosis. It should be something else, and the difference should be looked for in the histology. The differences between are primary histologic between in-stent restenosis of BMS and drug-eluting stents. So if you look at the DES restenosis, you have less cells. If you look at the BMS restenosis, you have more muscular cells in them. But how can we evaluate this histologic pattern without doing pathology, which is the case in our cath lab? Intravascular imaging of the OCT provides unique information in tissue characterization of in-stent restenosis. And you see the high resolution. You see a segment of 75 millimeter with investigated OCT here, very high axial resolution, very high sampling frequency. All this 75 millimeter segment was investigated in 2 seconds. Compare it with IVUS, 75 millimeter again, very low axial resolution and very low sampling rate. The whole segment you need 150 seconds. Now, for what use you choose OCT in the cath lab? In cases with in-stent restenosis, you want to know whether there are mechanical problems there. One of example of mechanical problems is underexpansion. As you see in this case, patient with in-stent restenosis has been treated with second and third stents, and you see the stent struts here, which are very, very underexpanded. The second use of OCT is to assess the underlying tissue type as much as we can without doing pathology. Here are different patterns of in-stent restenosis discovered with OCT. You see different patterns here, homogeneous, heterogeneous, layered, bridging architecture, periluminal intensity attenuation in the middle here, neoatherosclerosis here, neoatherosclerosis at calcium, neointimal calcification, neoatherosclerosis with a thin cap of fibroateroma. So you are able to identify different patterns of restenosis in these patients. But unfortunately, no data are available on which treatment option is best for which pattern of in-stent restenosis. Neoatherosclerosis is a newly identified histologic pattern of in-stent restenosis. It is more frequent with drug-eluting stents than with bare metal stents. On the other side, it appears earlier with drug-eluting stents than with bare metal stent. Here is a very recent analysis of more than 100 patients with in-stent restenosis coming from Spain and Germany together. And Dr. Jepa has done enormous work, because to look at the OCTs of 100 patients, it's a big, big job. And you see here that patients with in-stent restenosis of drug-eluting stents, they show neoatherosclerosis much earlier than patients with bare metal stent restenosis. Now, what is our desire, or RIP's desire, I would say, because we planned for a long time to do such a study. So this is a potential design of a randomized clinical trial looking at the tissue characteristics by OCT and deciding then to do treatment A or treatment B. It will not be a very easy design because you have probably to have a factorial design in this kind of study. So I would conclude with these messages. There are clinically important differences between in-stent restenosis after BMS and DES implantation. Intravascular imaging should be liberally used in evaluation of in-stent restenosis. Neathrosclerosis is a common cause of late stent failure in these patients. DCB or second generation drug-eluting stents are the preferred treatments for in-stent restenosis. And lesion preparation with scoring balloon angioplasty may improve outcomes in these patients. Thank you very much for your attention.
Thank you very much. Es el momento de empezar la discusión. Si los panelistas, los speakers quieren subir, por favor, please, to the panel to give the answer to the different questions. La discusión es abierta. A very short question for Adam. Do you think that is the time to modify the angiographic classification of in-stent restenosis?
To modify,
To change.
Sorry.
Okay.
To replace it with the OCT classification. Because you see, it's not enough for predicting the outcomes of patients treated for this pathology.
Maybe a factorial design with using OCT as a criteria in which with this method you see two patterns. We could say nephrosclerotic intima pattern, two of them, and factorial design for DS, DIP, or both, something like this. Could be an idea for really setting clear strategies, with evidence. And other comment, all the outcomes usually are angiographic in all the trials. And morphologic and angiographic outcomes. And we see TLR usually clustered around the angiographic follow-up. And we know that even clinically driving TLR is driven by angiographic findings. Why not to use IFR or FFR outcomes in these patients in the angiographic follow-up?
We are using them.
You are using
we are using FFR in patients with in-stent restenosis now. We are using OCT, but you know, it is becoming very cumbersome for the cath lab to have OCT, FFR, for something that is very easily treated. Because in-stent restenosis is easily treated. And you spend much more time with investigation that have not to do with the treatment, or they may guide the treatment, but just the decision for that. So that's, and usually these patients have symptoms. It's not that we are over-treating these patients.
I mean more from the follow-up of the comparison between
you have also to know, restenosis is a progressive disease. If the patient comes with 70% restenosis and he has no complaints, it is expected in 2 months to be 90%. It's a very progressive disease.
Question for Professor Kastrati. Maybe a practical message of your last talk would be that restenosis after bare metal stent may be treated with drug-eluting balloon, but restenosis after drug-eluting stent requires another drug-eluting stent.
So if you want to know, I was very pleased to see the data Fernando showed about the registry, the Spanish registry, from the 70,000 patients with PCI, 4% were with in-stent retinal 4.5%, and most of them were treated with drug-coated balloon. That means that although the results are superior angiographically for second-generation drug-eluting stents, most of the people stick with drug-coated balloon as first strategy for patients with this stent restenosis. And this is exactly what I do also. So that's for patients with one layer of stent coming with the first restenosis, I almost always you should individualize the treatment for sure, but it's you at the end, it counts what you do in the majority of patients. In the majority of patients, we are using drug-coated balloon as first-line therapy for first restenosis. If this fails, the second time we are using a second-generation drug-eluting stent. And we are combining. You know that some patients are coming 6 times after each other. There. But fortunately, it's a minority of patients.
So just to clarify this a little bit, I think the data that Pilar gave me is 4.5% of in-stent restenosis activity within our registry and 3.7% of use of drug-coating balloon in total, including a small vessel, bifurcation. So we don't know exactly, Pilar can correct me if I'm wrong, we don't know exactly the number of drug-coating balloons used in the treatment of in-stent restenosis. I don't know if this data is in the registry.
I can imagine it for sure.
Yeah, okay.
But the problem is that there are also second recurrences, third recurrences there. Yeah. That's why I find this number, 3.7% of drug-coated balloon, most of them for sure are used for in-stent restenosis.
Yeah, but be careful. In overall, DCB use is more frequent for de novo, despite the fact that there is no guideline recommendation. It's interesting. But this may have to do that ISR in total is a very rare event, and this may explain why the majority of DCB. I'm not sure about Spain, but overall, what I know is 60 to 70% DCB use is for de novo disease, not the ISR.
In Germany, is it the same? I have no data about that.
I have no specific, not for the specific countries, but I know some figures for worldwide use.
I miss more evidences regarding the APT after these treatments, because we are treating more and more patients in the very early stages with high bleeding rigs. We even implant DES in these patients. We have stents that can be treated with only 1 month APT or maybe 2-3 months. And when these patients come with the stenosis, we treat with these balloons, drug-eluting balloons, and recommendation is 3 months. But why is 3 months? What is the evidence for 3 months? Maybe it could be enough with 1 month, and we can save a lot of bleeding events in these patients. Why not to investigate more the APT safety period for drug-eluting balloons in restenosis?
I think we have, if you look at the last DAPT recommendations, the task force. Have you been there, Fernando, also in the task force of the DAPT? So it is unified for patients with stable angina, not having an excessive risk of bleeding, all irrespective of the kind of stent, irrespective of the kind of drug-coated balloon. The recommendation is 6 months. But it's more liberally used or reduced to 1 month for patients with treated with drug-coated balloon. So it is, we choose to have a very simple scheme. Otherwise, it's very complex. Yes. This algorithm with many arrows, they don't help. Yeah. If that's so, no one is looking at these details. So the majority of patients with stable disease, not having bleeding before, this is the most significant risk factor for new bleeding, a history of bleeding, they are treated with 6 months of that. I'm not talking about them with triple therapy. Huh? This is a different.
But I'm a little bit critical about this general recommendation, not differentiating between the different devices. Do you know what was the reason to do so, and not to? I mean, it makes a difference if you have an implant or not an implant, and it makes a difference if you have long drug release or not. This shows every data we have. So what was the rationale to do so?
The reason for doing so is the lack of evidence for doing in another way. There is no, for example, all our ISAR-DESIRE, I don't know the RIPS trials, all our DESIRE trials have been done with at least 6 months of DAPT. Why? You can ask, but why? It's
Exactly,
so.
why?
So
The
that the
question
task force is obliged to stick with the evidence.
But the point is, if you have in the one direction no evidence, you argue, then we do the other side, but there's also no evidence. So that's a little bit problematic, I would say.
All those that are against the recommendations, they should design new trials to prove their belief. No, but it's very difficult. This kind of, even for in-stent restenosis, for example, you see the number of patients included. All trials have angiographic outcomes, not clinical. How can you show a duration of DAPT better for 1 month or 6 months? Can you do a trial with 10,000 patients as it was the DAPT trial?
You know, that's the general problem we have meanwhile, because our therapies are becoming that good, have become that good, and that's the problem. It's very hard to establish anything new.
Bruno, on the other side, if young patient not bleeding during the 6 months, why not to continue? We have more and more data that antithrombotic therapy, even after 1 year, is having benefits.
I think that this is a really interesting question and topic, the DAPT in this context. There is another gap in evidence in in-stent restenosis, which is the CTO, in-stent restenosis CTO, which is really the most complex patients in this area. And this classically has been excluded in all the RIPS trials and probably also in yours trial. No, not yours. So why don't you try to, what to do in this case, in these patients? That's the first question, and the evidence is really scarce. What not to do a real trial for CTOs, for in-stent restenosis?
Well, the quick answer is that it's quite complex to do a trial including every in-stent restenosis that just concentrated in CTOs is going to be challenging. But as you know, there is a study from Spain that was published in your intervention, and there is some interesting results coming from this study. That is, Chema, I think, has got the data, right? Can you comment on that?
In the registry of CTO restenosis is the total registry, but was focusing the successful procedure of repermeabilization. It was mostly focused on the acute results. And we have also death and outcomes of 2-3 years. But the treatment that was 90% done with new DES, then it's very difficult to compare with the balloons, because in this case, when you open the occlusion, you have very long segments with very ugly angiographic results. And then that's why in the most of cases, the treatment is DES. Usually I can tell you, only the balloon, drug-eluting balloon was used in a very small percentage of cases, and usually in very small vessels when you don't want to put new stents. But it's not a registry that is able to give us any insights into this.
You mean in-stent restenosis of stents with which it was treated on CTO before, or in-stent restenosis presenting as CTO?
MERA type 4.
Yes.
I have a question in relation with the ISAR-DESIRE-III trial. When you compare preparation of the lesion with the scoring balloon versus conventional balloon, did you actually achieve a bigger acute lumen gain with the scoring balloon?
For sure, but I have not in mind now. For sure, it's shown in the baseline characteristics. It's always.
So you think the benefit of the scoring balloon is related with acute
I don't
result?
think that there was a significant result regarding the acute lumen gain, because we always try to get the best results before going to the drug-coated balloon, irrespective of we are using a scoring balloon or high pressure, etc., non-compliant. We try to get the best results, and I don't think that in this trial we deviated from this strategy.
One comment to the scoring balloon in QCA. I think it's very hard to show the benefits of a scoring balloon by QCA measurements. The scoring balloon gives you a more homogeneous stent expansion, I'm sure, and you have 3 points where you have higher pressure. I think if you would do OCT, maybe you could more differentiate between scoring balloon predilatation and conventional balloon predilatation, maybe.
So it's, if I to tell the truth, we use the scoring balloon not to improve the acute results. It was not our intention to do that. It might be that this is the reason for having the result, for having the better results. Our idea was just to increase the chances of drug penetration. This was our idea.
Dr. Kastrati, every ISAR-DESIRE trial has sparked a new strategy. Can you tell us something about the 5?
5, it will be based on OCT, for sure. But still,
you can tell me.
It will be for sure.
Do you think that the benefit of the scoring in stent restenosis is translated to its extensive and non-restenosic lesions?
I'm not using the scoring balloon for native lesions. So we are using it only for, I don't believe in the scoring balloon for calcified lesions. If it is too calcified, we are using rotablation. We are using high non-compliant balloons with high pressure. You know that there are now balloons with which you can dilate up to 40 atmosphere and more. So, but we are not using scoring balloon for for primary lesions. So I cannot say. I have no experience with it.
So my impression is from the data we have, limited data, that with specialty balloons, scoring balloons, chocolate or whatever, you may reduce the risk for flow-limiting dissections in treatment of de novo disease. So this is a sign I see, and therefore we are using it frequently for lesion prep in de novo disease.
I have a question for Alfonso. Es en relación al estudio AGENT. Teóricamente, el balón AGENT tiene la propiedad de tener más retención del recubrimiento, y por eso se diseñó el estudio. No se encontró ninguna diferencia en cuanto, a menos angiográficamente, entre el second please y el este. ¿Hay algún dato de OCT que pueda apoyar este potencial beneficio de la retención del fármaco?
Pues que yo sepa no. Realmente en este estudio las diferencias se han intentado, la no inferioridad se ha querido demostrar por la QCA, ¿no? Entonces probablemente la QCA no sea el mejor método para verificar la pérdida luminal tardía, ¿no? en un stent teniendo la OCT o el IBUS, ¿no? Pero bueno, hay que reconocer que es lo más barato y que posiblemente eso ha sido una razón. No obstante, bueno, los resultados han sido similares y parece que la concentración de la droga no influye en cuanto a el poner menos concentración, no influye respecto de los resultados. Puede ser que debido también al recubrimiento del trampas que tiene, ¿no? Ahora, yo sé que se ha hecho alguna comunicación puntual de OCT en la que se ha visto pues los cristales de depósito del paclitaxel en el vaso, etcétera, pero bueno, no sé cuánto puede influir eso en la restenosis.
¿Y esa tasa del 3% de trombosis del second please, esto es alguna justificación?
Es un 3% frente a claro, es 2 pacientes frente a 1, o sea, esa es la cosa, ¿no? O sea, hay 2 pacientes en un sitio, realmente con una muestra de 50 casos no se puede pensar.
May I ask in English? I think it was about thrombosis rates. This is one thing I'm wondering also for this trial. Overall, it was extremely high stent thrombosis rate, which is unusual for DCB treatment. Is there any explanation for how was lesion preparation done in this trial? Is there any information about this?
It was one patient versus two patients. What he was
One patient.
So the trial was underpowered.
50 patients in one group, 50 in the other, and one patient thrombosis.
I was struck by your registry data. You showed the registry also with a mortality rate of 8.6% at 18 months.
The mine.
Yeah.
Okay.
Did you include there also left main disease instant restoration?
Yes.
What was the reason?
Two
Because
patients.
8.6, it's too much for 18 months.
Endpoint is too much. This is a registry, no?
Yeah.
The median age of the patients was 70.
Yeah.
And
With left main disease, we see
left main,
numbers like this.
two patients with left main and two patients with saphenous vein graft. The rest of the patients were segments more common.
Fernando, you had the RIPS-6 trial with BBS. You were very courageous to approach also instant restenosis with BBS. What's about, I didn't see numbers of stent thrombosis with BBS in this series. It's small, but...
Yes, I mean, this is quite interesting because actually we were lucky to be able to finish the study with a very good group of investigators that did a very nice job because the results were much better than expected as compared with the literature regarding BBS. So we were happy in that regard. We, as far as I know, we got Javier Cuesta is again here, the guy with the fine data, but we got a thrombosis in the BBS group in a patient that discontinued prematurely the dual antiplatelet therapy. So the two, I think, was aspirin and clopidogrel, I don't remember. Those were discontinued, I don't remember, 2 months, 3 months after BBS implantation in this patient presented with a major ST elevation anterior MI.
2 months after implantation?
2 months, 3 months, 3 months.
3 months.
And then there is another patient that is not counted in this study because the thrombosis occurred after 1 year. And again, this patient was a funny patient because there was, in the follow-up, we noticed like an ulcer in the edge of the BBS, and we did nothing for that. The BBS was otherwise looking excellent, and that looked like a plaque rupture outside the BBS edge. And I think 2 months after, no, 1 month, 2 weeks after discontinuation of the dual antiplatelet therapy beyond the first year, so this is not being reported, the patient suffered a major stent thrombosis, and Fernando Rivero opened up the artery, but it was a major cardiogenic shock and the patient died. And we sent the autopsy data to Michael Joner, and I think he's publishing the case. So that we got 2 cases as far as I know, and I think we've been very lucky as compared with the literature because, well, if there is a concern that BBS perhaps got this higher risk of stent thrombosis, and you use these stents in patients with in-stent restenosis, even though we were as carefully as possible to avoid small vessels, avoid the, yeah, but you say that in the protocol, and then we broke the rule a couple of times here in a very small vessels, so then you go to the real world and you use the BBS in small vessels, and we did that. But our data are very good. Clinically, good results, and as I explained, restenosis, minimal lumen diameter, and percent diameter stenosis very similar to those that you can see with drug-coated balloon. Now, with the information we got, with the body of information we got from BBS, I will guess that Bruno will be very, very happy to say, well, if the results are similar, and there is a concern at least a theoretical concern that the risk of thrombosis could be higher after BBS, I think drug-coating balloons got a good opportunity window here to enter in the leave nothing behind area.
Talking about DBS, you have also the seven RIPS, which is investigation on VVS restenosis. But in my view, this is a different animal compared to DES restenosis because you don't have a metallic thing with tissue inside. You have a dismantled scaffold because restenosis is going to count at 1 year or 18 months. And then we have to start again to investigate if it's good. Drug-eluting balloon in this non-structured thing with straws that are floating, connected with tissue atherosclerosis, and maybe the best strategy for BBS restenosis is a metallic DES, in my view.
Yeah. This is a very good point. It's the only patients in which I don't think twice and put a metallic drug-eluting stents were patients with BBS restenosis. Exactly for this, what you said.
I would like, if possible, to ask Manolo Panis there with the best series in Spain on BBS in stent restenosis, and perhaps they can provide some data. They published that in Revista Española of Cardiology. And then Manel should illustrate us about this dismantling thing. I mean, we don't really understand the dismantling of BBS, why there is encroachment of the BBS at late follow-up, whether or not this is frequent. I mean, you were quite pioneering with this data. Is there any information, probably not yet published, that we should know, or we can?
No, basically the mechanism we think is just the very late collapse in this vulnerable period that comes around 1 year and a half, this 18 months. We experience a couple of very late scaffold, and then we perform OCT, and we show this collapsing struts and discontinuities, or what is the name, or whatever name it is, but basically you see areas where the scaffold is infra-expanded, which was not the case at initial implantation. So, and probably it's due to the not healthy resorption of the scaffold. Maybe the scaffold was not well embedded in the plaque or in the tissue, and then when you start this resorption, then fall into the lumen and then create this magma for the thrombosis. That is our hypothesis, of course, that just based on several instances of this thrombosis. Whether PSP or the classical predilatation, sizing, postdilatation may improve this or not remains to be demonstrated, or the thinner strat scaffold resolve this problem. This is something that we don't know yet, but hopefully in the future we may answer this question. PSP was one of the questions for Bruno in this, because he discussed, and also Adnan, about the predilatation of instant restenosis, and probably you should. Probably it is already in the trial when you design a trial how to perform the treatment of ISR, but maybe to create a PSP for treatment of instant restenosis by drug-coating balloon, that could be interesting, maybe.
I think that PSP had a bad omen.
Yeah.
And you don't need to stick to this omen. If you want not to have the same fate of BBS for DCB.
I heard a talk a few days ago. We had a meeting in Birmingham, and one of the proctors who did proctoring in the US gave a talk about PSP, and it was more like this was the version for the Americans because they need something simple. And hopefully we can do more differentiated therapies in the future. But then comes the question: what would be the new classification, OCT based? Does it predict, like the marine classification, really the outcome or not? So I think there's a lot of work to do before we can do more differentiated ways of ISR treatment.
If we join the efforts, it's not impossible, because the study of Roxana, for example, had something 700 patients with angiography. OCT is much more sensitive. I'm sure that you need 500 patients to reach the same what Roxana reached with 700 patients.
Is there any question from the audience?
I have a question.
Yes, absolutely. John.
Yeah, just a practical question. So, if you treat a drug-eluting stent restenosis with another drug-eluting stent, do you use a different stent just because the first drug failed, or you don't mind to use the same stent again?
So this was exactly the idea behind the ISAR-DESIRE-II trial. We tested between paclitaxel and sirolimus for sirolimus in-stent restenosis there, and we expected better results for Taxus exactly with this concerns behind, because we thought this is a resistance against sirolimus, and so we have better chances with another drug. And actually, we achieved better results with Taxus because, as I said, it was the first time that we had comparable results for Taxus and Santer. But not to that extent that you believe in this theory. And now, on the other side, you don't have any options. It's, I will not go back to Taxus now for venous restenosis. So it's everolimus is everything now. Everolimus, sirolimus, sotarolimos, but it's, you don't have any other. So you can say whether I can use instead of chrome, cobaltum, platinum now another metal, but for the substance you don't have options.
Okay, I have heard Dr. Kastrati opinion, but I would like to know the opinion of the rest of speakers and panelists. Do you really use in daily clinical practice drug-eluting balloon for the first drug-eluting stent restenosis? Or do you keep this therapy for the second or third restenosis? Because according to the result of Reeves Fourth, the results are better with drug-eluting stent instead of drug-eluting balloon.
Mm-hmm. So I wanted to do a pool here of opinions.
We personally treat
in the panel.
First with
Who
the
is
balloon.
for DCB as first line of treatment for DES restenosis? First line.
First line.
If you see a DES restenosis, you use DCB as first line instead of a second DES. Who is for that?
That's true, but we're very strict in the acute result.
And
As long as we don't have...
For those who
Yeah.
use a second drug-eluting stent, how many layers they wait for before using a DCB?
It depends on the characteristic of the restenosis, the geographic characteristics.
No,
this is very important.
We are talking about proportions. Not sure, we individualize our therapy, but at the end you have proportions.
But the important is that for us it's the first line treatment, but we are really demanding with the geographic result. As long as you don't have a good residual stenosis over 25% or you have dissection, we put a stent.
Yeah, I'm
but you
not
are right.
talking about dissection,
First line exactly
or
is the
mechanical
balloon.
problems, etc. Yeah.
The first line is the balloon. If the geographic result is quite good, is the first line treatment. This maybe means that in
my view,
80% of the restenosis
it's
leave
okay.
the capillate with the balloon and only 20% with a new stent.
Manuel.
this is not a black or white answer, I think.
No.
As many things in life, as you can see nowadays. So, in my view, it depends on first, will you prepare the lesion and how the result is. That's for sure the main question. Second, what type of vessel, the length of the restenosis. If it's focal, I go for a first line balloon. If it's a diffuse in-stent restenosis, I go for a verolimus routing stent as a first line. Depends on the anatomy, depends on the vessel, and how many layers. If you have already failed twice or three times, I go for surgery. I don't go for a. If it's a lady.
Yeah. Have you seen differences between drug-eluting stent and DCB related to restenosis morphology in your ribs? Because in our DESIRE-III, we didn't see. So you had the same treatment effect across all the 4 morphologies.
So coming back to first, what therapy would I choose? I still nowadays, I will choose a second-generation drug-eluting stent because I'm pretty convinced now that the angiographic results are better and that this is translated into a superior clinical benefit. Today, we will give Manel Sabate and Rosana Hernandez all the data of the 3 years follow-up, which is prepared by Javier. I will present at ETCT, and I may be wrong, because perhaps the curve that were not so different will teach me that there is no clinical difference. And that will be a major change. And actually, I have no idea what the result is going to be. But I will know the data for TCT. I should be presenting that, so I will be more reinforced. Now, there is the other thing is that not every restenosis is similar. I mean, there are cases with a proximal in-stent restenosis that you will pay whatever to prevent the patient coming back. And unfortunately, some of these patients are patients with a couple of layers already. So it's a proximal LED, you are considering surgery, perhaps. Well, I will do my best in this case to prevent lumen narrowing and TLR. In other cases, well, smaller vessels, even though the subgroup analysis we performed was unable to show any differences, I will be more willing to accept a result of a drug-eluting balloon that at the end, if you see the Kaplan-Meier curves, are also very good. So it's a statistical significant, but I mean, you see the numbers, it's whatever, 95% versus 85%. I will be able to buy any of those. And I think this clinical setting, which is very difficult to summarize scientifically, plays a role to me. There are patients, I will do my best to reduce the fear of restenosis, because in some patients you see that this patient will be coming back, and I will pay whatever price to prevent that. And no, I don't think we have data about the morphology of restenosis, although if the morphology is diffuse versus focal, I think the data are similar.
I remember a study done in our center maybe 20 years ago with in-stent restenosis. We looked at the risk of re-restenosis depending on the times of restenosis before. And it was very interesting. We got an increase by 10%, 20% the first time, 30% the second time, 40% the third time. It was almost regular, the increase.
So in a way, those patients with multiple metal layers are those at higher risk of restenosis, yet it's not very elegant to keep using the same device that failed. So on the one hand, you will, in those cases, will try to avoid another layer, but if this is the patient coming back, well, perhaps we should still offer the best potential strategy.
No, I think it's right. It's not black and white, it's clear. But on the other side, in a cath lab with many fellows, with many young interventionalists, you have to have a line. So which is the first idea that will come to their mind if they are having a first restenosis? Then there are for sure details, and they call you to give an opinion. But this is what I asked here. Which is the first idea to come in mind if you see an in-stent restenosis? And here is the majority was for DCB, for you to answer your question.
Okay, thank you very much. We will close the session. Thank you very much for the speakers and for the panel, and thank you for your attention.